Hello everyone. I'm going to be presenting the renal medications, which really can be anything from an antibiotic for just a simple urinary tract infection, or drugs that actually affect the mechanics of the kidney or enhance the kidney function. So here we go. Okay, medications for UTIs are sulfas, as you can see. And I know you've already learned antibiotics, so should be a little bit of a review. We know that they're bacteriostatic. They suppress bacterial growth by inhibiting synthesis of folic acid, which really we know folate is a compound required by all cells to produce DNA, RNA, and proteins. Many bacteria have developed resistance to sulfas. We remember that sulfonamides were the first drugs for systemic treatment of bacterial infections. It's very old. It works on meningococci, streptococci, and shigella. Considered to work against a broad spectrum of microbes. And here's more listed here: MRSA, Listeria, Chlamydia, Protozoa for toxoplasmosis, funguses. Today's principal indicator for sulfas, because we have so many other groups now, is for urinary tract infections. 90% caused by E. coli. Sulfa does a very good job in the urinary tract. As you can see, it achieves good solubility, but it also does a very good job against E. coli to this day. Most severe hypersensitivity is the Stevens-Johnson syndrome. We've mentioned that a couple of times, and you'll be writing to that on your med cards, but it's a rare, serious disorder of your skin and mucous membranes. It's usually a reaction to a medication or an infection. Often Stevens-Johnson syndrome begins with flu-like symptoms, followed by a very painful red it's like a purplish rash that spreads and it blisters on the skin. Then the top layer of the affected skin dies and sheds. Make no mistake, Stevens-Johnson syndrome is a medical emergency that usually requires hospitalization. Treatment focuses on eliminating the underlying cause, controlling symptoms, and minimizing the complications. Trimethoprim is also a sulfonazole. It's initial treatment of an uncomplicated UTI. And E. coli drug is contraindicated in patients with folate deficiencies because of what it does to folate, such as megaloblastic anemia, pregnancy, and lactation. And then our fluoroquinolones are ciprofloxacins. All the acins, as you can see in ciprofloxacin, ends in ACIN, are fluoroquinolones, or we also call them just quinolones. Moxofloxacin, norfloxacin, and levofloxacin. And they're pretty much narrow-spectrum quinolone antibiotic used only for UTIs. Cipro, oral or IV, can be used for respiratory, GI, tract, bones, joints, skin, as you can see here, soft tissues infection, also for preventing anthrax in people who have inhaled anthrax spores. Very good for UTIs and very broad spectrum. Nitrofurantoin or macrobid for uncomplicated UTI and bladder infection, cystitis, and then Bactrim and Septra. Our urinary analgesic, and you can't really see it there, but it's pyridium, and that will turn the urine orange. That should be a little bit of a review too. And then now we're going to talk about diuretics, and they're the big ones that affect the kidney tubules itself. And they block the reabsorption of sodium and water, creates osmotic pressure within the nephron that prevents the passive reabsorption of water. Diuretics cause water and solutes to be retained within the nephron. In doing that, it promotes the excretion of both. And diuretics interfere with the normal operation of the kidney. In doing this osmotic pressure, so it can cause hypovolemia because we're pulling off fluid, acid-base imbalances, and pulling off fluid, we just said, sodium is not going to be reabsorbed, and then altered electrolyte levels. These side effects can be minimized by using short-acting diuretics and by timing drug administration so that the kidney is allowed to operate in a drug-free manner between the periods of diuresis. So classification of diuretics. Basically, our four main categories are our high ceiling loop diuretics. An example of that would be Lasix or furosemide. It's in a class of its own where this drug does save lives. Thiazide diuretics, or hydrochlorothiazide, and we're going to talk about these separately, are potassium-sparing diuretics, meaning you're diuresing, but it doesn't let all the potassium wear out. They would be our aldosterone antagonists and our non-aldosterone antagonists. And then for osmotic diuretics is a mannitol. So let's look at these each separately. Our high-ceiling diuretics, most effective diuretics available, they are our powerhouses. These drugs produce more loss of fluid and electrolytes than any other diuretics, and Lasix, again, is the best example of this. It acts in the ascending limb of the Henle's loop to block reabsorption of sodium and chloride. Remember, sodium and chloride are very similar. By blocking solute reabsorption, furosemide prevents passive reabsorption of water. About 20% of filtered sodium chloride is normally absorbed in the loop of Henle. So interference here, you have profound diuresis. We give it orally, IM or IV. Therapeutic uses, you can see, are many. Congestive heart failure, pulmonary edema, edema of hepatic, cardiac, or renal origin that has been unresponsive to other diuretics. We also give it for hypertension that cannot be controlled by other diuretics. Because it is so powerful, it is not usually the first diuretic or low blood pressure medication we use. They save it for later when other things are not working. And again, the site of action for Lasix is going to be in the loop of Henle. They are referred to as loop diuretics because of that, because of where it takes place. IV diuresis will begin 5 minutes after administered. That is how powerful. If the person has a Foley, you can see it. All of a sudden, it's filling with 1 dose of Lasix IV. It's therapeutic in renal failure. It can promote diuresis even when the renal blood flow and the glomerular filtration rate is low, that we just talked about when we looked at the pathology of the kidney. Adverse effects, it's washing out everything. So the adverse effects of Lasix is not easy. It's not hard. It's not hard to understand. Hyponatremia, hypochloremia, hypokalemia, so all of the electrolytes. Ototoxicity, it's another one that can cause that. But I haven't heard of that. I don't think it's that common. Dehydration makes sense. It's washing all the water away. Dry mouth, unusual thirst, oliguria can promote thrombosis and embolism because people are dehydrated. So the blood is kind of sitting there and not moving like it should be. And again, low blood pressure because we're pulling all the fluid off. So it's a really good idea. We need to know what the potassium and sodium levels are before we give it. We need to know what the blood pressure is before we give it. And then I want to talk about digoxin a little bit. Digoxin is used for heart failure and cardiac dysrhythmia. So when there's an arrhythmia it's not a normal sinus rhythm. In the presence of low potassium, the risk of serious digoxin-induced toxicity is greatly increased. And the biggest thing about digoxin, it can cause ventricular dysrhythmias, and those are the ones that are not compatible with life. High ceiling loop diuretics promote potassium loss. Use of Lasix with digoxin can increase this dysrhythmia risk. Most patients in heart failure need digoxin and Lasix, so therefore potassium levels must be monitored closely and heart rates and rhythms. We know that with these two drugs. Okay, the thiazides, let's talk about those. Hydrochlorothiazide or hydrodiuryl diazides, and just another one, used extensively for hypertension, but it is classified as a diuretic. It promotes urine production by blocking the reabsorption of sodium and chloride in the early segment of the distal convoluted tube. So it's a little bit different, almost does the exact same thing as Lasix, but in a different part of the kidney. Retention of sodium and chloride in the nephron cause water to be retained as well, causing an increase in the flow of urine. These drugs are ineffective if the GFR is low. So if somebody's already having a problem with their kidney, the thiazides are not going to work. Used for hypertension and heart failure. Adverse effects, looks pretty much the same story, right? When you're washing out water, you're washing out electrolytes. Hyponatremia, hypochloremia, dehydration, and hypokalemia. Aldosterone regulates water absorption by the distal tubules and changes urine concentration by increasing sodium reabsorption. Remember, aldosterone is known to pull the sodium up. A high plasma concentration increases sodium and water reabsorption by the tubules and decreases sodium and water excretion in the urine. A low plasma concentration promotes sodium and water excretion. It helps control the secretion of potassium by the distal tubules. High concentration increases the excretion of potassium. Other factors that affect potassium secretion include the amount ingested, number of hydrogen ions secreted, potassium levels in the cell, and amount of sodium in distal tubules, and again, the GFR. And then our aldosterone antagonists. What does this do? These are drugs that block the receptors for aldosterone. Eplerenone is the first in this class for selective aldosterone receptor blocker. Greatest concern here is going to be hyperkalemia. Spironolactone is less selective. It causes more side effects, both used for hypertension and heart failure. This one also binds with receptors for other steroid hormones, such as glucocorticoids, progesterone, and androgens. So why would we use this for hypertension and heart failure? Because we know that aldosterone regulates water reabsorption by the distal tubules and changes urine concentration by increasing sodium reabsorption. So it's making the heart work harder because of sodium retention. In the kidney, activation of aldosterone receptors promotes excretion of potassium and retention of sodium and water. Receptor blockade, as in eplerenone, has the opposite effect. It retains potassium and increases excretion of sodium and water. So we're getting rid of the water, but we're also increasing potassium. So patients with heart failure, eplerenone can improve symptoms, reduce hospitalizations, and prolong life. But hyperkalemia, potassium supplements, salt substitutes, or potassium-sparing diuretics are contraindicated with these drugs. Yes, it's a very good diuretic, but we have to be looking for hyperkalemia, because this one is going to work for high blood pressure and heart failure. And I think that's all that's going to fit on this one. We've got a couple more to talk about, so I will have another video. Okay.